Patients with advanced cutaneous squamous cell or metastatic cutaneous squamous cell that receive Cemiplimab, the studies looked at either 1 or 2 year exposure to the medication. So we have follow-up for just shy of a year in these patients, looking at the response that's maintained. The guidelines that were done in the clinical trial were as long as the patient was tolerating and maintaining response, that they continued for either 1 or 2 years. Now that we have access to the medication, the label recommends that, again, we continue this medication for as long as the patient's tolerating or there's a clinical response. This is an area that really needs further study. I'd say that, for example, in melanoma, where we use these checkpoint pathways much more commonly, we're still struggling with the idea of how long do we keep patients on, what are some of the monitorings that we need to do later on, can we stop the medication? So these are ongoing questions with Cemiplimab in cutaneous squamous cell cancer. As far as toxicity management or monitoring, at each dosing there are standard blood tests that are recommended, such as thyroid monitoring every six weeks or so during infusions. And as we all know now, that these toxicities can occur even months after starting the medication or even stopping the medication. Toxicities can occur, so they still need to be involved in their healthcare team. I also think it's important to bring in all the support that the patient has, such as their primary care doc, their dermatologist, should all be aware. In fact, at our institution, we've implemented a banner system. So in the electronic medical record, if a patient's on these medications, such as Cemiplimab for this indication, if they hit the emergency room or another healthcare environment within our system, a pop-up window will alert the provider that this patient is on this particular medication. For that patient that either doesn't get a response with Cemiplimab or experiences a response and then progresses, that's an opportunity to go back to the multidisciplinary tumor board, have a discussion again. For example, sometimes a patient may have a response that makes surgery or radiation an appropriate modality again, so I'd consider that. And then going back to the tumor board, we also have clinical trials that we can look at for newer agents or combinations of agents in this indication.